I've enjoyed today's meeting, and to be one of the speakers with Dr. Smaldone and Burnett and Hu and Keibel is really an honor. So thanks to Jay and to the rest of the board for the invitation. It's great to be here. This talk is going to be specifically about genetic testing, and I think last year, this meeting, you guys may have talked about genomic testing, which are a lot of the biomarkers, and Mark talked about some of the biomarkers in prostate cancer that are being used. But here I'm going to be talking about inherited genetic factors in prostate cancer. And this talk is entitled Who, Why, When, and How, but I realized after I put the talk together that really it's why, who, how, and when in that order. I do have a few disclosures to put up there that just highlight that I have a disclosure with Myriad Genetics, who does some work in genetic testing. So, you know, there's a whole Twitter community of physicians and patients, and I'm sure many of you are on Twitter, and actually there are some amazingly interesting and good discussions that take place. And you know, when you have a tough patient, actually people will post for information on Twitter. And so this came up recently. A 57-year-old gentleman with Gleason 6 prostate cancer, one core only of cancer, so it's not very much cancer. PSA is 3.6. Father and brother have a history of prostate cancer. One was advanced. Patient and family have a BRCA2 inherited mutation. And the question is surveillance or prostatectomy appropriate? Patient had a normal MRI. And so, Jay, can I put you on the spot? Would you consider surveillance here? Or you would?
57-year-old Gleason 6, Ebola family history.
BRCA2, yeah.
I would.
Yeah, okay. And so I'll tell you, there was a huge discussion that ensued, and there were disparate views. I'll tell you my view of this by the end of this. But right now we do not know what the right answer is. And so, you know, the fun thing about Twitter is you get something. I'm going to show you some papers later by Mike Fraser, for example, who's chimed in, has done a lot of great research in this field, a lot of, again, disparate opinions, because BRCA2 connotes a more aggressive prostate cancer. So we don't know, you know, the things that we think we know about surveillance, we don't necessarily know for patients with inherited factors that makes them susceptible to more aggressive prostate cancers. Of course, when we talk about BRCA or the BRCA gene, everybody knows all about it and thinks about women and risk of breast and ovarian cancer. And so the CDC has these infographics, all in pink. Women need to know about the BRCA gene or BRCA gene, know your risk, lots of information out there. But there is virtually nothing about BRCA and MIN. And so I took the liberty of making this infographic, you know, a little Photoshop, and this is what we need. And so a lot of what I'm going to talk about is going to make this case that this is a really critical issue for men and their risk of prostate cancer, and possibly impacting their management when they have prostate cancer. This is starting to gain some traction in kind of the lay press. This is a recent article in the Wall Street Journal, the genetic test some men don't know they need. This came out last month. New York Post a week or two ago published this one, How Men Can Be Affected by the BRCA Gene 2. So I think many of us are seeing more and more of this, and I'm sure many of you have noticed that too. So first is why, and Simon Sinek says start with why. So that's where I'm going to start with this presentation. And I want to draw clarity around what we're talking about when we say the genetics of prostate cancer, the genetics of inherited prostate cancer, because there's genomics that people talk about, there's other markers that people are talking about, and this is a unique piece of this. And so this is, for those of you who took or remember high school biology, this is the central dogma of biology, cells. DNA is replicated in the cell, it then is transcribed into RNA, and then it's translated into proteins, and we're basically just a big conglomeration of proteins. Proteins are what make us us in many ways. And so the DNA is a long ways upstream of the proteins, which affect kind of that signal in our cells. And in fact, only about 2% of our genome, 2% of all of our DNA actually codes for proteins. And so there's a lot of dark matter, things that we think don't matter, but actually probably they matter at some level. And actually some of the genes that are inherited that seem to increase the risk of prostate cancer occur in that dark matter. And so we're not really sure necessarily what that means. If it's not turning into a protein downstream, how is it increasing the risk of prostate cancer? And so that's an issue that still remains to be solved. So again, where I'm going to be focusing this talk is around the DNA that's replicating in cells. And again, here's the big picture prostate cancer continuum of care that goes from early detection to diagnosis and staging, treatment, and then survivorship after treatment. And many of you are familiar with a lot of these tests in here from PSA, but more advanced or newer tests like the Prostate Health Index or the 4K score, Michigan Prostate Score, SelectMDx was a urine test. There's the genomics that Mark talked a little bit about, Prolaris and Oncotype DX and Decipher. But in many ways, genetics has become this elephant in the room that impacts any of these stages potentially. We still aren't sure exactly how it should impact at each of the impact treatment or detection, but we're beginning to understand it better. Why would we consider germline testing? Well, there are a lot of aspects of clinical care that it could help impact. It could impact risk assessment, so what is the probability of disease, the probability of prostate cancer. It can impact prevention. Is the disease risk modifiable? For example, women with the BRCA gene, women found to have a BRCA mutation, may consider certain drugs, hormonal therapies to decrease the risk of breast or ovarian cancer. They may consider an oophorectomy or a mastectomy prophylactically. Germline testing may have an impact on prognosis. So maybe disease is more aggressive in the setting of specific mutations, and that's certainly true of the BRCA2 gene that I'll talk about. It may impact treatments. That's also something that comes into play with prostate cancer and certain mutations. And then it can have an impact just beyond the patient himself onto their family members, their brothers, sisters, daughters, sons. And why is this all happening now? Well, I've often, and probably some of you have seen this comparison of the cost of sequencing to Moore's Law. And Moore's Law is this, truth about computer chip speed and cost, and it's gone down at this steady state forever. And initially, if you look here, the cost of tumor sequencing or cost of genome sequencing, cost of sequencing a whole person's DNA just was going down, ticking along right like Moore's Law. And so you can see here the max cost here is 100 million. Just keep in mind that the Human Genome Project, which took many, many years to sequence the first complete genome, was $3 billion. And so it was ticking along, and then really the bottom fell out. And the cost dropped way down, and so now it costs about $1,000 or less to sequence most or all of the genes in our genome, which is remarkable. So a huge change in cost that's really disrupted the field. And when we talk about prostate cancer that's inherited, there's a few different categories here. And one is defined as hereditary prostate cancer, which is when we actually really identify a gene, a known gene that increases the lifetime risk of prostate cancer. That's about 5 to 10% of prostate cancers. Genes like BRCA mutations, Lynch syndrome, which is known to predispose to colon cancer or upper tract urothelial cancers. So that's hereditary cancer. Then there's also a pool of patients with a strong family history, but no clear gene that necessarily is responsible for that, yet to be identified, or maybe it's not there, and so it could be a combination of genetic and environmental risk. Certainly close family members have an increased risk, and so that's this broader or maybe somewhat less precise category of familial prostate cancer. And then there's all the other cases of prostate cancer where we don't see a genetic mutation that predisposes to prostate cancer. We don't see an increased risk that's related to family history. It's just all the other prostate cancers, and that's about 70 to 80%. And there really are a lot of components that factor into those say 20 to 30% of cases that are familiar or hereditary at some level. And so at the bottom of this pyramid are some of the more common variants. And some of them are called single nucleotide polymorphisms, and I'm going to have a slide on that in a second. And those come from studies that are genome-wide association studies, really huge, big data studies. We have tons of patients. Look for the tiniest little change in DNA. Oftentimes those changes are in the dark matter of the DNA. And often when we find those, it does increase the risk of prostate cancer or other cancers, but the effect size is really small. So it's just a really tiny incremental increase in prostate cancer risk. Those are the most common variants. And then a notch above that are the genetic changes that have a moderate effect size, genes like BRCA1, BRCA2. There's some others listed here that are well described in prostate cancer, HOXB13, MSH2, which is a mismatch repair gene, and CHEK2. And so those, we know how to find those, and they have a moderate effect size. And then there at the top here are genes that are really rare and have a very large effect size, and at this point we don't know of any of those in prostate cancer. Maybe they exist, but I think it's unlikely at this point. It's true in other diseases. And so here, just as a brief explanation of the SNP, or single nucleotide polymorphisms, this information comes from these really large scale observational studies that look at all these individual little changes in DNA, often in the dark matter of DNA, looking at patients with prostate cancer and without prostate cancer, unaffected and affected individuals. And it's a big data problem. So feed a lot of data in, and then you start to identify each of these little changes, each of these little SNPs that we all carry in our DNA, and then each one is a tiny incremental increase, but pooled together often. People have developed these polygenic risk scores, they're called, that say, okay, well, if you have one, it's not really that important, but if you have 100, then that seems to confer a substantially increased risk of developing prostate cancer. The genes themselves with a moderate effect size, most of the ones, almost all of them really that we're talking about, are in the category of DNA damage repair genes, and so that includes BRCA1 and 2, because you ask yourself, what is it that these genes do actually that increases the risk of prostate cancer? And it's probably not surprising to you that DNA, as it gets replicated, there are changes that mutations that occur there, basically just transcriptional errors, basically just errors in the fidelity of that DNA being copied from one strand to the next. And it can get, sometimes one strand gets broken, sometimes they both get broken, and so then there's a whole mechanism in the cell to repair that. And there are all these different categories, whether it's double-strand break repair, which is broken up into something called homologous recombination and non-homologous end joining or non-homologous. These are things, we don't need to get into the details. There's mismatch repair where the DNA is supposed to be, copied in a certain way, but it's actually matched, the A is matched to something it's not supposed to be matched to. And so there's another set of genes that protects against that. And so it turns out that when there's a defect in the genes that participate in DNA repair, much greater likelihood that a mutation will take hold, get replicated, that faulty DNA at some level will then get passed along to another cell, and then another cell, and then eventually can lead to a cancer forming. And so that's kind of the fundamental issue of the fundamental mechanism that causes these gene mutations to result in increased risk of cancer. And then you have to ask yourself, well, what's the difference between a gene going awry? How do you end up with a gene that goes awry that's inherited versus a gene that goes awry that's not inherited? And it goes back to where, how our chromosomes are passed down from one generation to the next. And so if we have a gene that's passed along in a sperm or an egg, then that gene, that mutation, is going to be passed to all of the cells in that person. And so that person so all the cells in the offspring carry one mutation. An allele is basically another word for a chromosome. So one of the chromosomes is going to have that mutation. And then all of this, or half of the sperm or half of the eggs for a woman would then have that mutation be potentially passed around to the next generation. So that's a germline mutation. And then a somatic mutation is not inherited. And so that's where the mutation occurs in a specific cell, like in the prostate. And so that prostate cell has now gone awry and can lead to a cancer. That's a somatic mutation. But it's just in the prostate. That abnormality is just in that one spot, and it cannot be passed to offspring. And so there really are two different paths in activation of these DNA damage repair genes. And so they can be inherited, so they're passed along, and that's the example here in green. And so if they're inherited, they're passed down, then again, one of those chromosomes is abnormal. It takes two chromosomes abnormal for that gene really to not work anymore. And so in addition to that germline inherited risk, there also has to be some change, a somatic mutation or some other change that happens in the other allele or the other chromosome that leads to it leads to cancer in that cell. Whereas without that inherited gene, without that inherited risk, you need two hits. You need the first somatic hit on one chromosome and then the second somatic hit on the other chromosome, and then that can lead to cancer developing. So just bringing back to prostate cancer, there are a bunch of studies looking at what are the rates of these mutations in patients with prostate cancer. And so this study just doesn't separate out germline and somatic. And it looked at some of these key DNA damage repair genes and said that of 477 men with intermediate risk tumors, about 10% had mutations in these genes in their prostate cancer. In patients with metastatic prostate cancer, the rate is much higher. And so this is a study out of led by Rul Chennai at the University of Michigan. And it showed that about a quarter of patients with metastatic castration-resistant prostate cancer had changes in one of these genes. Now, of those, about half were somatic only, and about half were inherited, so it can be either, both. And then the field really changed with this study, which was published in the New England Journal of Medicine about 2 years ago, and it was, I think a shocker in many ways for all of us. We knew that this was important. We didn't know how important it was. And so what they showed in a large study of 692 men led by the group at the University of Washington, Fred Hutch in Seattle, they showed that 12% of these men with metastatic prostate cancer had germline. Again, now we're ignoring the somatic mutations, but just had germline mutations in DNA damage repair genes. And so that's really high. It's in line with breast cancer field. And it tells us that we have not been paying nearly enough attention to this issue in prostate cancer. And most of those, by the way, were almost half were mutations in BRCA2, and then BRCA1 was another 7%, and then some of these other genes made up the rest. But almost 60 or 70% were kind of the 3 or 4 key genes here. What proportion of men with localized prostate cancer have germline mutations predisposing to prostate cancer? About 0.5% is the rate of BRCA1 mutations, about 1% is the rate of BRCA2, and about 0.5% is the rate of ATM. So it's lower in localized disease. And so that also really speaks, if you think about it, to the increased aggressiveness of prostate cancer in the setting of some of these mutations. If you say, well, there's only 2% of men with localized prostate cancer have mutations, but 12% in men with metastatic prostate cancer, tells us that those men with mutations are much more likely to end up developing metastatic prostate cancer. And so this chart, or this table, gives you some of the estimates for increased risk associated with some of these germline mutations. And so for BRCA2, you can see the increased risk of prostate cancer is about 3.2 to 8.6. For some of these mismatch repair genes, it's about 2 to 4. For another gene, HOXB13, it's about 3 to 8.5. And these genes also they don't just predispose to increased risk of prostate cancer, they predispose to increased risk of early onset prostate cancer. And BRCA2 in particular predisposes to an increased risk of aggressive prostate cancer and increased risk of death related to prostate cancer. This is another study that was looked at 800 patients, 800 men, comparing men with lethal and non-lethal prostate cancer, and it showed that in men with lower risk localized disease, the rate of BRCA mutations and ATM mutations, another one of these DNA damage repair genes, was 1.5%, and in lethal cases, the rate of mutations was 5.5%, again, speaking to the increased risk of aggressive disease. This is the same study. Does this arrow work? No. And so we've seen a bunch of these Kaplan-Meier curves already today, and basically what it's showing is that so the entire cohort included some men with metastatic disease, and so they looked at both the entire cohort and just those patients with localized disease. And if you look, you can see that patient non-mutation carriers, which are shown in blue, had much better outcomes than patients with mutations that are shown in the orange here. And then we have to just ask, okay, if we accept that this is really important, which I think hopefully we all do, then what do we do about it? So which patients with localized prostate cancer should undergo genetic testing? How do we implement this? Is it practical? And what are the implications for screening and early detection? And then, should we treat patients with low-risk cancer differently, like Jay and I were talking about earlier? And should we treat patients with high-risk cancer differently if they have these mutations? So first, next I want to go to who. Which patients should undergo germline testing? And there are now guidelines around this. And I hate to say it, but the best guidelines for prostate cancer genetic testing are in the high-risk assessment of breast and ovarian cancer in the NCCN. And so I think many of us hope that they change the name. They really need to, because there's a lot of content in here on prostate cancer. And so these are the NCCN guidelines. These have been shown earlier as well, and I'm sure many of you are familiar with this. But I'll just highlight kind of what I think is the punchline of this NCCN guideline related to prostate cancer is the question of who should undergo genetic testing with prostate cancer, and it spells it out really clearly. And I think this is as good of a recommendation as we have. This isn't based on an immense amount of data, but it's grounded in solid data from a lot of real serious experts in this field. And so this is it. Personal history of Gleason 7 or greater prostate cancer with, then either one close blood relative, and close isn't that close, by the way. It's first, second, or third degree with ovarian cancer.